A very good afternoon to everyone who has joined us for our third MedStrom webinar. I'm Debbie, MedStrom's Clinical Director, and I'm accompanied by my colleague Helen, who is Sales Director. We are receiving some really wonderful feedback from our educational webinars. The number of people joining us are really increasing. This webinar has the highest number of delegates to date, with approximately 400 people joining us. We extend a warm welcome to all the clinicians who have joined us today. We thank you for your time, and we also offer a welcome to industry partners who are joining us today. We have kept our invitation open to all in the interest of collaboration and open learning.
Today's webinar will begin with Dr. Natasha Larmie. Natasha is a GP with over 20 years of medical experience. She has appeared as an expert commenter on This Morning and CNN, as well as being featured in the Huffington Post and The Independent. Dr. Natasha has an interest in mental well-being, weight management, and women's health. Natasha's session discusses her personal story and how this affects her approach to patient care.
At about 2:20, we'll hand over to Tracy Carr. Tracy works as a consultant to several leading healthcare companies and as an advocate for better healthcare for plus-size patients. She has developed seminars on maintaining dignity of care for the supersized, which she has delivered at a wide range of hospitals and clinical training establishments across the UK and Europe. In addition, she works as part of a team delivering training in the moving and handling of plus-size patients. Tracy will be speaking from the patient's perspective, giving her personal experience as a receiver of care.
At approximately 2:35, the last presentation will be from Mr. Shaw Summers. Shaw is an NHS consultant surgeon with over 20 years' experience. He was a senior lecturer at St James's University Hospital in Leeds, West Yorkshire, and an associate professor at the Prince of Wales Hospital in Hong Kong. Shaw is a past president of the British Obesity and Metabolic Surgery Society. He has presented Channel 4's The Food Hospital, he's Discovery TV's Fat Doctor, and has appeared in many TV programmes as a surgical expert. Shaw will discuss the challenges that healthcare professionals and hospitals may encounter striving to achieve dignified care for patients.
In order to maximise your time with such great speakers, we won't have a break during the next hour. We'll gather your questions during the sessions and address them at the end. You can click on the bottom right-hand icon, which is labelled View Sidebar, when you hover over it, and enter a question. This can be done anonymously and privately. We strive to address as many questions as possible, but if time doesn't allow, we'll email the responses to all.
At the end of the webinar, we will also post a brief poll, and a survey will follow after the event. We would really appreciate your comments, as our focus is to gather your feedback so we can keep creating engaging webinars for you soon. So let's start with the first presentation and welcome Dr. Natasha Larmie.
I am very delighted to be here. This is a subject that is very close to my heart, not only because I'm a GP and have been doing this job for quite a few years, but also because I am a fat woman. So that's why I call myself the Fat Doctor sometimes, because I am both fat and a doctor. So this presentation is important to me for many reasons. I'm challenging the weight normative approach. This talk is all about how we can replace weight stigma with dignity, care and respect. I have, over the last year, been very actively involved in campaigning against weight stigma within the medical profession. As I said, it's personal and professional. And I'd like to explain to people who don't necessarily know what weight stigma is and how it impacts society and patients. So the objectives of my talk is to sort of talk a little bit about dignified patient care and how weight stigma has an impact on this. And then also to go on to talk about how to become a weight inclusive health practitioner, which is the way I identify as a doctor. So to begin with dignity, there's a famous quote by a PhD and an author named Linda Bacon, who is one of the founders of the Health at Every Size movement. And that quote is, "All bodies deserve respect and care." And I think that everybody listening today can agree with that. The GMC says you must not allow your personal views to affect the treatment that you provide. In particular, you must not refuse or delay treatment because you believe that a patient's action or lifestyle has contributed to their condition. And that's really important, and I'll go on to discuss why. when I talk about weight stigma, I've been talking about it for a long time, and I assume everyone knows what it means, but of course most people don't. Weight stigma refers to the devaluation within our society, in this case on the basis of body weight alone, so that people who are higher weights are subject to prejudice and discrimination. And this impacts us in all areas of society. It impacts us in schools, in the healthcare system, in the media, in the criminal justice system, in the workplace, definitely within the workplace. In fact, several studies have shown that weight-based discrimination is reported to be on a par with discrimination based on race and gender. Now, we are often talking about racism and sexism, and that's very important, don't get me wrong, I'm not suggesting that we shouldn't be, but I also think that since weight-based discrimination is on a par with these things, we need to be talking about that too, especially since weight-based discrimination tends to intersect with sexism and racism. Explicit bias is one form of weight-based discrimination, and that's basically overtly negative attitudes, disliking of fat people, blaming fat people for the way that they are. You know, it's because they eat too much and they don't exercise enough. It's their fault. They should take more responsibility for their health, etc., etc. Also, fear of becoming fat. That's a form of explicit bias. And I've given an example here, just one example, which is obese people are entirely to blame for their weight gain, and they need to eat less and exercise more, something that I have heard time after time after time as a patient and as a friend and a family member and all sorts of things. Implicit bias is much more pervasive, actually. It's an unconscious attitude that you may not be aware that you hold. And growing up in a society, you know, for the last few sort of decades, really, that has been obsessed with weight loss, with thinness and the morality of thinness, most people nowadays have some form of implicit anti-fat bias because of the society we've grown up in. It's not something that we can control, and that also manifests itself in lots of different ways. An example I've given is that you may, as a healthcare provider, choose to spend less time with a patient because they inhabit a bigger body, and you kind of make the assumption that it's going to be a waste of your time. So there's lots of dangers of weight stigma within the healthcare profession. Loss of trust is a very important thing. Patients lose their trust in us. They lose their ability to communicate effectively with us. They hide things from us because they don't want us to know, because they're afraid of being shamed. There's also reduced compliance. Everybody knows that if you don't trust a doctor and you find it very difficult to communicate with a doctor or nurse or whoever you're talking to, then you're far less likely to do as they suggest, or take the medication that you're supposed to take, or follow their advice. And here's the big one: avoidance. Patients who have been stigmatized tend to avoid medical practitioners like the plague because they're so afraid of going to see them and being shamed or laughed at or judged or humiliated, especially since they're experiencing these things throughout all walks of their life, in their homes, in their schools, amongst people that are supposed to care for them and love them. So they don't want it from a doctor. They don't want it from a nurse. So they tend to just avoid. And that's really, really important. There's one study I often like to quote, which is based on the last global pandemic, the swine flu pandemic, in which they looked at all of the people that had died from swine flu. And they found that, yes, as suggested, there was a link between obesity and swine flu deaths. They were talking about that since swine flu began in 2009. But in 2016, when this study was published, they found that when you adjusted for delayed treatment, the link between obesity and swine flu deaths disappeared. So what that meant was, it's not the fat itself that caused people to die from swine flu, it was the delayed treatment. And that's something we need to be talking about more. Also, internalized weight stigma, holding it all in and keeping it to yourself, actually has been clinically shown to cause poorer health outcomes. So weight stigma is very dangerous for our patients. So what is weight inclusive care? Weight inclusive care is kind of the opposite of what most people are doing at the moment. And I want to talk to you a little bit about how to become a weight inclusive practitioner. So first of all, I want to remind you of the fact that we are supposed to practice fairly and without discrimination. That's something that actually the GMC it says it's compulsory if you're a doctor, and I'm pretty sure that the NMC and any other body that one belongs to probably has something very similar in their code of conduct. Practice fairly and without discrimination. That means that we shouldn't be ignoring symptoms and assuming they're weight related. We should not be declining examinations because we don't like the idea of examining somebody in a larger body. And if you think, gosh, that never happens, don't kid yourself. There are studies to show that that is the case, that doctors have refused breast exams and gynecological exams, and because they don't feel comfortable doing that in someone in a bigger body. As I mentioned, don't blame weight for symptoms. Look for other causes. Do the same investigations as one would do for somebody in a much thinner body. Don't delay treatment because this person is large. If someone comes to you with a high blood pressure and you think, chances are they're going to need to go on treatment, you have to start treatment. You can't look at them and say, maybe if you go away and lose some weight, you might, drop your blood pressure a bit, because chances are that person will leave your surgery and they won't come back. And then instead of having high blood pressure a couple of months, they could end up with high blood pressure for a couple of years, maybe 5, even 10 years before they figure out that there's something wrong. You should be engaging in conversations about health behavior and lifestyle. And it is perfectly possible to do this and to be weight inclusive. Just because you're weight inclusive doesn't mean you don't talk about diet and exercise. That's definitely not the case. Another thing I want to remind you about is the fact that we need to respect autonomy. Okay, when we are treating patients as doctors, certainly, and I think as any healthcare practitioner, we're not supposed to be telling them what to do. We are supposed to be helping them to make an informed choice. Okay, it's not about giving them advice, it's informed consent. That means that we have to talk about the benefits, the risks, the side effects, and the alternative treatments, including the option of non-treatment. And if there are those amongst you saying, well, there's no risks of going on a diet, don't kid yourself. That's not true. In fact, there are multiple risks, short-term and long-term, when it comes to prescribing weight loss. Not only do the majority of diets fail, in fact, 95% of people gain weight after they, 95% of people, I do beg your pardon, regain the weight that they lose. 2/3 of them actually end up heavier than when they started. But also the dieting comes with a number of side effects. It tends to lead to disordered eating patterns. Disordered eating patterns can lead to eating disorders. They also are the biggest risk factor for obesity later on in life. So if you start dieting young, chances are you're much more likely to be obese later in life. So prescribing a diet is not necessarily the right thing to do. Exercise, I've just read a journal article, I think it was released yesterday, that talks about the dangers of endurance athletics and how men between the ages of 40 to 65 who were exercising for more than 6 hours a day ended up with higher risks of high blood pressure and higher risks of coronary artery disease, that it's actually a J-shaped curve, and there is such a thing as too much exercise. Fascinating stuff, just the first study I've ever read about it, but fascinating stuff nonetheless. So there are side effects, there are risks, and we do need to be informing our patients of that as well. Do no harm makes a lot of sense, guys. We know this. Do no harm. Avoid stigmatizing patients. Don't ignore their mental and emotional issues, and environmental and cultural and spiritual factors as well. All of these things are massively important. A patient is not a blood pressure, they're not a blood cholesterol, they're not a blood sugar, they are a human being, and you have to consider all of them. Otherwise you end up causing more harm than you do good. Also, it's our responsibility to challenge our own bias. And so if you don't want to harm your patients, you've got to be careful not to allow your bias to seep in to your own medical practice. Finally, focus on behavior, not weight. Weight is not a behavior, it's a number on a scale. You could have somebody who is exercising and eating a very healthy diet and still is overweight. You could have somebody who is a perfect weight and has a terrible lifestyle, high blood pressure, and is very, very high risk of developing a stroke or a heart attack within a few years. So don't treat weight, treat behavior. Finally, let's talk about best interests. You've got to consider so much about what you're doing with your patients, the environment that they're in, the equipment that you use. Giving patients gowns that are too small or blood pressure cuffs that are too small, beds that don't fit them, is not acceptable. We cannot be doing this to our patients. We have a responsibility to every single one of them. Our body language and our non-verbal communication is so important. Your face says a lot about how you feel about a patient. If you look disgusted, they will feel judged. And of course, your choice of words, your words and your communication is so important. That's why we spend so much time learning about it when we're studying for our, respective professions. As I said, weight is not a behaviour, and it's important to focus on health behaviour and not weight loss. I also say to people, you've got to keep up to date. As a doctor, I've had only like a couple of hours worth of training about nutrition in my whole entire career. You cannot advise a patient about nutrition if you've only spent an hour learning about it. If the information that you get comes from Cosmo rather than from actual medical studies, then there's an issue, and you need to keep up to date with the relevant information. So thank you everyone for listening to me. Just a reminder that all people deserve dignity, care and respect. I hope that you enjoyed that, and I'm going to hand back over to Deb now. Thanks.
Thank you so much. On behalf of everyone listening, I'd like to thank Dr. Natasha Larmie for providing us with a practical approach to dignified delivery of care for all patients, regardless of weight. Natasha gave us fantastic practical tips for becoming a weight-inclusive practitioner, which is very in line with recent requests for clinicians to adopt a health at every side approach to care of all patients. We thank you for your tips on considering the environment, ensuring the equipment doesn't make patients feel uncomfortable or not accepted, thinking about the choice of words we use, focusing on positive behaviours and the need to gain education to keep ourselves both up to date and to challenge our own beliefs. I'm going to hand over now to Tracy for the next session. Please remember to ask questions that can be raised with our speakers at the end.
Hi everybody, my name's Tracy Carr. I'm here to give you a personal experience of what life is like for a plus size patient. I'll tell you a little bit about myself. I'm 53. At my heaviest I was 242 kilos, 38.5 stone. Currently I'm about 175 kilos, which is 27.5 stone. And when I was born, I was 3 kilos, which is 8 pounds. So I've kind of been everywhere in between. My background is very boring. I had a very ordinary childhood in a very average size family. Lots of outside activities. I was pony mad. Lots of home cooked food, no junk, no fizzy drinks. I was average size. So now I work as an office manager. I also lecture part-time at university, talking about bariatric studies, helping nurses, doctors, physios and OTs to understand a little about how it feels to be very large. I also help companies develop new products, R&D, consultation for bariatric products. I film training videos, and I talk to people like you as an advocate for bariatric patients. My life is very boring. I work full time, I pay tax, I vote, I look after my home, my garden, I drive an ordinary car. I'm somebody's daughter, somebody's sister, somebody's co-worker. I have a long-suffering partner, and it's all very ordinary until it comes to accessing healthcare, and then life tends to be complicated. I'm not an advocate for being large in itself. I wholeheartedly don't recommend it, but I think we've all got to do the best we can to fight discrimination, to seek equality of care, to achieve the best outcomes for our individual patients. But also it's important as a society as a whole that we recognise that we're all different and we all deserve equal respect and dignity, and particularly dignity of care. So one question I get asked quite a lot is, how did I get so fat? People don't usually word it quite like that, but it is a valid question. So having grown up in an average sized family, I had mild depression starting in my late teenage years, some comfort eating, some tendency towards obsessive compulsive behaviours, and I gained some weight until I was about 18 stone, about 115 kilos. Life was normal. I played badminton, I played rounders, active, busy. But at age 30, I lost my partner in an accident, and my life kind of spiraled from that point. So I ended up with clinical depression. I was an IT project manager. I couldn't work for 2 years. My obsessive compulsive behavior was out of control, and I gained a lot of weight very quickly. After 2 years, I returned to work, but life was very difficult, readjusting to everything and to losing my partner, and I continued to gain weight until at my heaviest I was 38.5 stone, and life at that size is very difficult and very tiring. So how does it feel trying to negotiate life at that size? Well, I guess the obvious thing to say is you feel very visible. I can't hide my, so say, condition. I can't pass. I can't dress differently to disguise it. So you end up in a position where your life and your life choices are judged by complete strangers on the street. I'm seen as lazy, stupid, uneducated. I'm seen as a drain on the healthcare system, probably a drain on the benefit system as well. The media paints me as lazy and feckless, and sort of suggests frequently that I'm willfully damaging the NHS through my greed and my lack of willpower. And that's quite a lot to carry around with you every day. Every time I'm seen in public, I'm judged, whether that's a supermarket queue, wherever. I'm very aware of people's judgment and whispered comments and sideways glances. And one thing I would sort of say to you is, like, when I'm stood in a supermarket queue, I could be stood next to a functional alcoholic or a weekend drug user. I could be next to a tax defrauder, a drunk driver, a child or animal abuser, and none of those things show on the outside. They're all hidden and inside, but my, so say, crimes, my bad habits, my situation is visible for all. So that's how it feels. You feel very visible, very defensive, very vulnerable, really. You know, I've had incidents in public. I've had somebody spit in my face purely because I was fat. I've had somebody follow me around a supermarket and who actually accosted me and took things out of my trolley. And my other half, who is tall and slim and thinks green food is green because it's gone off, not because it's a salad. The pizza that the lady took out of my trolley was for him, not for me. But of course it was quite a distressing situation, and I abandoned my trolley and went home without shopping and probably didn't venture out again for another few days. Most of the time I can deal with it. Sometimes I can't. I try to be charitable and to be sympathetic to the people who judge me, but yeah, some days I don't. Some days I don't cope. And you know, at the moment I'm trying to lose weight. I exercise, I do my steps, I wear my Fitbit, I eat the rainbow, trying lots of different colours, trying to eat raw food, unprocessed food. But if I have a really bad experience like that in the supermarket, then my obsessions resurface. the self-soothing behaviour, which for me is comfort eating, resurfaces, and it kind of goes back to square one. When you're bigger, lots of people will abuse you and dress it up as concern. They're just worried for me, you know, a complete stranger that they've never met before. And fake sympathy is one of the hardest things I find to take. But I try to be brave. I try not to take it home. I try not to let it impact me. But every word, every comment does have an effect. And I'm lucky that I'm fairly self-confident. But somebody with less confidence, it can make the difference between them choosing to withdraw from society altogether. Something else I'd say is, unlike an alcoholic whose health improves the second they stop drinking, or smokers when they put out the last cigarette, their health automatically improves, weight doesn't just disappear. When I'm on a maintenance diet and I'm eating 2,000 calories a day, my weight stays exactly the same. The problem doesn't go away. So to resolve my health issues, I need to actively get into a calorie deficit, and that's hard to maintain for days and weeks. But when you're looking at maintaining it for months, years, or maybe even in my case decades, it's a lot harder. The struggle goes on, but it's, you know, it's a constant one. So I'm very lucky. My health is generally very good. I have normal blood pressure. I'm not diabetic. I'm not pre-diabetic. Being big is exhausting, but I think, or I'm told by all my middle-aged friends, that we're all in the same boat, feeling knackered all the time. So about 2 years ago, I had my first real run-in, I think, with the healthcare in an acute setting. I was breathless at home. It came on over the course of a weekend, and the house was being decorated, and I assumed I'd maybe got an allergy to the paint. I went to my GP on an emergency appointment, but it turned out I had a pulmonary embolism, a saddle PE sitting across both lungs. We don't really know what caused it, but it was possibly due to a long haul flight. So I had 3 weeks in hospital. I was stuck on a trolley for 11 hours while they tried to source a bariatric bed for me. When they found a bariatric bed with a inflatable mattress, I watched, slightly bemused, as somebody tried to persuade me to get onto it when it was upside down. It happened to be a product I was familiar with, so but if I hadn't been aware of the product, I would have been put on the bottom of the inflatable mattress. I didn't fit in the CT scanner, so I had to wait a few days while it was arranged and then transported by ambulance to a different CT scanner to come back. It was an interesting experience, but you know, I'm very grateful for the care I received. There was no specific rehab though, so after 3 weeks of more or less constant bed rest, I had deconditioned to quite a significant extent, and it took me a very long time to feel that like life was back to normal. Then more recently, 18 months ago, I had an epigastric hernia quite high up in my diaphragm. In the 18 months, I was admitted 9 times for inpatient pain relief because they told me I was too heavy to operate on. Finally, in August 2020, it got so bad that there was no choice, and I was an emergency admit. I had a repair. I had mesh inserted. Obviously, because I was an emergency, they didn't have a lot of time to plan, but the bed, etc., was all in place very rapidly, which I was grateful for. There was a couple of incidents that stand out, though. While I was waiting for the operation, I was on the trolley waiting to be transferred to the table. The nice anaesthetist had explained everything, and I was, you know, just about to go under. And there was a big delay, and one of the nurses actually said to me, "Oh, we're trying to find a way to transfer you from the trolley to the table." So I said, "Well, I can do that myself," which confused everybody, because I think just by looking at me, they judged that I was, you know, not mobile and active. So yes, with a bit of help with the drip, I was able to just transfer myself to the table. But if I hadn't, if the nurse hadn't mentioned that that was the problem, I probably would have been, you know, had my operation cancelled or been hoisted or something, just because somebody wasn't communicating properly with me. And whether that's they were worried about offending me or what, I don't know. But it was kind of yeah, chastening experience. But I was quite lucky. I had quite an interested physio who helped me work on rehabbing me and getting me up and about again before I was discharged, which was great. Discrimination is a hard subject, and sometimes in healthcare, every consultation, every encounter feels like a battle. I am aware that during consultations I'm defensive, and I wonder if that makes me prickly and oversensitive to deal with. I'm very lucky that I'm confident, I'm articulate, I'm able to do my own research. I'm still conscious, though, every step that I may be up against somebody who can't see past my size. And I worry about people who can't advocate for themselves and how their healthcare outcomes are affected by that. One of the issues with being big is that every conversation you have, the person you're talking to brings their own experience of food, their own experience and issues of difficulty with their own weight, and they bring that to the conversation. So if they are of average weight and able to maintain that easily, then they sometimes don't understand my situation. If they battle hard with their weight and keeping it under control, sometimes they don't understand why my issues are so much worse than theirs, and there's a lack of sympathy. I think, you know, I'm very grateful for the chance to talk to you all today, and I would say kindness and understanding that people come in all colours, all shapes, all sizes is the key to providing dignified care. The United Nations Declaration of Human Rights gives me freedom from discrimination for colour, creed and religion. And it doesn't say only if you're thin. You know, my rights are the same as everybody else's. So you may not be able to imagine how it feels travelling through the world at this size. And as I said, I absolutely don't recommend it. But I would say, imagine maybe that I'm your loved one. I'm your daughter, your mother, your sister, your auntie, whatever, and try and encourage yourself and to encourage your staff to treat me as you would like to be treated. And I'd also say call out discrimination and prejudice when you see it. So be an ally, and the first step to doing that, to achieving that, is to attend training sessions like this and to engage in these conversations. So thank you so much for caring about the subject, and thank you so much for listening to me. I really appreciate that I had the chance to talk to you today. Thank you.
I hope you found Tracy's comments about the patient's perspective and experiences thought-provoking. We want to give a heartfelt thank you for such a personal and emotional presentation for us all, and actually the insight into how you are made to feel on a daily basis. The psychological battering that Shaw will go on to speak about was illustrated in your candid comments. It's quite shocking to hear about some of the experiences that you've discussed. I hope we can all take what you have said on board and be an ally, and again educate ourselves on both our understanding and provision of dignified care. So our final speaker is now going to speak to us about challenges that healthcare professionals and hospitals may encounter striving to achieve dignified care for patients. We now welcome Shaw Summers.
Well, thank you very much to both Helen and Deborah and to Medstrom for giving me the opportunity to talk about a subject very close to my heart. I will just share my screen and launch the presentation. And there we go. Good. So how do we give dignified care for patients with obesity. I've been working in surgery as a consultant for the last 26 years, and probably for the last 30 years, I've had a side specialist interest in the management of obesity, because I was lucky enough to work for a surgeon called Steve Pollard in Leeds, who was one of the first bariatric surgeons in the country. And I've really grown to understand, firstly, the patient's viewpoint. My father was very big, and I really saw what in effect that has on people's lives, on their hopes, aspirations, their treatment by others. But also I saw the absolute paucity of understanding and dignified care for patients struggling with their weight when they come to access NHS services. And with the onset of treatments for obesity becoming available worldwide, I saw the way the NHS just was not interested, not even interested in making treatment of any illness comfortable for patients who are heavier than they would like to be. So I really give tribute to the last two speakers, to both Natasha and Tracy, for really quite insightful and incisive talks about the lived experience of patients with obesity. And I think we all need to call out discrimination and stigma when we see it. But what I'd like to do in my talk, if I may, is to just introduce the obesity problem from a medical point of view and look at obesity-specific issues in healthcare. And I'm very grateful to some of my patients who've consented to me taking photos of them having their treatment journeys, because it really does help illustrate the things we have to consider as healthcare professionals when we look after patients struggling with their weight. So this young man has attended for his weight loss surgery. It is the most effective treatment for patients with severe obesity. By severe obesity, it's what we call morbid obesity, but obesity enough to cause an illness. And the patients that require treatment are defined by criteria, which I'll talk about in a bit. But there are 2.25 million of them in this country, 3.5% of the population. 10% have defined obesity. So we're not talking about a minority group here. These are 1 in 10 of the population who require dignified care, not just being bunged through a normal system and expected to cope. So why do people become obese? We know it's not laziness, stupidity, greed, sloth, any of those things. There are a number of very important intrinsic factors within the body that lead to a higher chance of becoming obese, both genetic, environmental, psychological, etc. You can't control eating and your food intake as much as people might think. It's a bit like control of your breathing. You can hold your breath for a while, or you can breathe shallow for a while, but after a bit, your brain takes over and tells you to just breathe. It's exactly the same with eating. Try going on a long-term diet. Sooner or later, you crack and you eat stuff because your body is telling you to, and it's really difficult to override that. And that, at its basis, is why some people just can't keep weight off. There are also lots of metabolic reasons. Some people burn energy faster than others. It's down to their innate metabolism. Some people keep eating when others feel full. It's down to the genetic switches that tell you you're full. We know that human anatomy, physiology, genetics in the round hasn't changed very much. But what has changed is the way that the environment, the world around us, interact with those genetics. So urbanization of populations, industrialized, commercialized food supply. People make money out of feeding us. The rise in personal expectations. We watch Bake Off, we watch all the MasterChef programs, and we want to eat like they cook. It's just not real, and it's just not good for us. And then there's the subtle epigenetic environmental changes, be that pollution, stress, television usage. All these things change the way our bodies work and make us more likely to put on weight. And then, as our last two speakers have explained, the psychopathology of obesity, the fact that we just start to really berate people for putting on weight, and that gives them all kinds of problems dealing with this feeling that somehow they failed and they need to do something themselves when it's not in their gift to do so. We need to be aware to recognise all these things and to start managing them. It is a real problem. It's very expensive for the country, for the world as a whole. And the bottom line there is that obesity makes every illness harder and more expensive to treat. Is it important? Well, in terms of cause of death, yes, it is. It's at least up there with breast and bowel cancer as a direct cause of death in the population as a whole. We do have NHS services. These are clear evidence-based guidance based on criteria as below for the body mass index, and we should be providing these services. NICE have approved it. The commissioning boards have approved it. Where are they? We don't even scratch the surface in this country of giving patients choice of treatment for what is a medical condition. There is a pathway of care, a pyramid shape, tier 1 being community-based, tier 2 being specialist community-based for the GPs, tier 3 hospital-based, multidisciplinary weight services for severe obesity, where I live at the little tip of the pyramid, dealing with those who are really suffering medically with their obesity. As I said, it's between 2.25 and 2.5 million people. We know that weight loss is powerful medicine. You can cope with being heavy in your youth. It's just a lot to carry around. There's a lot of stigma there, but physically you get on with it. But it's as people reach their 40s and 50s that the weight starts to cause real medical problems and hardship. We know that weight loss will help reverse some of those and actually make their quality of lives better. So what do we really have to deal with? Bias and stigma, very important. I won't dwell on that because Natasha's done such a good job of explaining it. Access to care, very important. It's woeful at this moment in time. Making the appropriate environment. You can tell a hospital that has a bariatric service in it because every ward has big beds and big chairs for those patients who need them. And the person-centered approach. People struggling with their weight are human beings too, and they deserve dignity and quality care rather than just being put up with. So this is the kind of thing that I faced when I first started developing one of the first bariatric services in the south of England about 10 years ago. I would approach commissioners about setting up an NHS service, and I would get sniggers and laughs about, well, why do you want to be treating fat people? They could just eat less and move more. The problem is they are all out there. This young lady was in her early 20s and was institutionalized because of her weight at a vast cost to the society and a huge cost to her own personal well-being and mental health. The WHO in 2017 has issued a full document. I'd encourage you to read it and encourage you to go to a site like Obesity Action and look at their weight stigma. We need to call this out wherever it happens. It's every bit as bad as race and gender stigma. But unfortunately, there are barriers within the profession. Doctors, nurses, healthcare providers, all are guilty of a degree of ignorance about what services there are to help people with obesity when they ask for help. Prejudice that they should be accessing services paid for by the taxman, protectionism of resources, disbelief of the data, etc., etc. The fact that GPs don't refer patients who are eligible for obesity services has now been thought to be a potential cause for negligence. Weight loss surgery, weight loss treatment is not cheap, but it is very, very cost effective. One other psychological barrier is with the patients themselves. They've been told it's all their fault, so they are in, a state of what should they do? Should they just hope that there's a new diet, a fad, a tablet, something else out there? And the diet industry really doesn't help with this, making sort of unsubstantiated promises that they can help you lose weight when we know that it's not usually long lasting. The shame side of things is really very difficult. We've learnt our lessons now that putting big signs up like the 4 children at the bottom, which was tried in southern United States, to try and illustrate that childhood obesity was a problem that the parents need to tackle, it made matters worse. The children involved felt worse about their obesity because the attention was being drawn to it. So we have to start getting rid of societal prejudice and learning that these people need help if they wish it, and the help needs to be effective and constructive. So here's our bariatric unit. You can see each, it's a proper bay with curtains. Patients are in appropriate beds. There are appropriate numbers of staff to help them, and there are various aids around the department. But we've got to consider not just the environment, but clothing, the ability of patients to move themselves, handling equipment if they can't, but also systems and protocols of care that enable this to be done safely for both the patient and the staff. That means big chairs, big transport, and appropriate environments in and out of theatres. So that includes on the left here a commode, so that they don't have to sit on a wall-mounted toilet and potentially break it, proper scales, and in clinics a variety of seats, some without arms, that patients who have a large size can sit in without embarrassment or without feeling that they're going to be at risk. Beds are really important. The bed on the left, not appropriate. It's not the right kind of bed for that kind of patient. Bed on the left, perfectly appropriate. A good mattress, good side supports, the patient's comfortable. So back to my young man who came to the theatre, you can see he's got a mobility aid to help him get out of the wheelchair and onto the table so that he can do it his way, not being manhandled. Surgery needs to be safe for the staff, so my anaesthetist has got a platform to stand on to access the patient safely, and I've got all the right kit I need to do a safe keyhole operation. And then at the end of the surgery, patient wakes up, he's giving a little thumbs up there, and the anaesthetist is happy. And a day later, he's sitting on the high dependency unit in a nice, comfortable bed, happy that he's had his treatment. Does it work? Absolutely. And in terms of the actual care, we have a multidisciplinary team. Very important to have a team of people who are all specialists in looking after plus-size patients. There is an integrated care pathway so that there's set daily goals that patients achieve. We know when patients are falling behind and something's not right very quickly. There is a requirement to nurse all our patients sitting up, and we early mobilise them. They realise that the lady that comes round to get them out of bed is called the physioterrorist for a good reason. Any deviation from perfect, we investigate. We don't leave things to chance. We have things like the hover mattress, which if this will play, it might not. Yep. So this is a mattress that enables us to move a plus-size patient without manhandling them across from the theatre bed to the trolley, and we actually put them straight onto their hospital bed. So there you see 2 ladies just pull this patient across without any trouble at all. What can be achieved? Well, we can do things for very specially heavy patients, like this gentleman in his early 40s who was basically housebound because his abdominal apron was so big he needed a modified Zimmer frame to get it around. I managed to take off the excess apron, do bariatric surgery, 10 days post-op, ready to go home, and a year later, half his body weight, back to work, mobile and independent. What can we do? We've got to educate people. We've got to educate healthcare workers, politicians especially, and the public to make absolutely clear that plus-size patients, obese patients, fat patients require and expect every bit as good healthcare as the rest of the population. Thank you very much.
Thank you, Mr. Summers, for providing us with some great insight into the experience you've had and the ways that potential challenges can be overcome. I hope you all enjoyed the focus on dignified care and discussion of stigma around weight bias, effects on access to care, psychological barriers, appropriate environment, including the furniture and equipment. Again, a key focus on education around this area was highlighted. So we have time now to answer some of the questions that have been submitted. So Mr. Summers, if I ask you to remain with me, and if I can ask Natasha, Tracy, as long as your tech is holding up, and Helen to join us for questions. Before we do proceed though, we have some published 3 short questions in the poll section in the sidebar, which will allow us to collect feedback to help with future webinars. We hope you'll take a few seconds to answer them, particularly if there are areas of interest you would like to hear those with experience speak to you about. So let's go to some of the questions.
So the first question is for Shaw. In your experience, what are the most common barriers plus-sized patients face when accessing healthcare services?
I think the biggest barrier is probably stigma and prejudice, I'm afraid to say, and also ignorance. Doctors don't know what they can do to help patients who request treatment or help, whether it's for obesity or for another condition. They just take one look and judge and just think that weight loss is the answer. So I'm afraid that is. I think the second is a lack of recognition by the NHS and the commissioners that this is an issue they need to address. If they don't, the line at the bottom of my slide from Public Health England is that obesity and its increasing incidence in this country will make everything so difficult to treat. We'll run out of money standing still.
Thank you.
Thank you.
So the next question is for Dr. Larmie, and you touched on this in your presentation. How can we promote health at every size model in practice?
I think the most important thing is, as I said before, is to remember that weight is not a behaviour. So the difference, I think, between myself and, say, a colleague who does not have a weight sort of health at every size approach, is that often weight becomes the focus of their lifestyle intervention. And I'm not talking about people who are sort of the type of people that are going to see. Sure, I'm talking about the majority of people that we see in the GP surgery. They come in to see us, their BMI is slightly higher than we'd like it to be. And so we tell them that they need to lose weight and bring that BMI down. What we should be telling them is that we would like them to be more active, that we would like them to work on their stress management, to get enough sleep, to look at their diet, all these kind of behavioural things, cut down on smoking, stop smoking, cut down on alcohol, all of these health behaviours. That's what we should be focusing on. And when you make weight loss the goal, the focus of your intervention, what happens is you start to lose weight. That's great, and you feel really good about yourself, and then you start to that starts to fail. You know, you're no longer losing as much weight, and then you feel really bad about yourself, and then you're more likely to give up. When you take weight out of the equation and you measure success by, you know, the fact that people are going out and exercising 5 times a week, then they're much more likely to stick with that. And if they're more likely to stick with that over time, their health will improve. And there are a multitude of studies that show that. So I think I just say, just take weight out of the equation. It's not that difficult. You're still going to be giving them the same advice. You're just simply removing the weight loss talk, and that's what we got to do.
Thank you.
Okay, so Tracy, I'm glad you've joined us. Sorry about all these problems with the technical stuff, but I'm glad you've been able to join us because we have a question for you. How can we reassure plus size clients that they will be treated with dignity when they are admitted to the hospital?
I think the first thing is make it clear that you have the tools and the experience to deal with the client. Make it feel like business as usual. It's not an exceptional event. If needs be, put on your professional game face and do your research behind the scenes. Don't stand in front of your patient and go, well, I don't know what we're going to do with you. Because as a bigger person, that just kills your confidence in the professionals that you're dealing with. So do it behind the scenes. Have a panic attack behind the scenes, not in front of me, please. I don't want your stress on spot to deal with as well. Practice your skills. I have very mixed feelings about the use of bariatric fat suits. I've seen them used very inappropriately, but in the right circumstances, they can be helpful. But your first port of call should always be to book a plus size model. Ask me if I'm available. I will come and help you. I will let you practice your moving and handling skills. I will tell you how it feels when you do X, Y, and Z. I will tell you which parts of my body feel unsupported and which positions make it difficult to breathe. So yeah, find a real human being and practice your skills, and do all of that behind the scenes, not when you're in an emergency situation.
Thank you, Tracy. Some very valid points there.
The next question we have is actually for Helen. The question is, I'm struggling to find a bariatric tilting shower chair or commode for a patient who requires a 33-inch seat width. Do you have any recommendations?
It's interesting actually, because there's a lot of comments in the right-hand bar around restrictions around equipment. Where do we access equipment? So Medstrom have a very wide range of bespoke accessories as well as beds and mattresses for the plus size patient. We have a full team of clinical advisors who go and do patient follow-up. We do training. We do, for this particular lady, we do have one of our specialists, Kirsty, who will be in touch to help you with your specific requirements for this individual patient. Also, if I may, Debbie, we've also been asked around CPD. Medstrom also offer a range of CPD courses. They're all available to view on the Medstrom website, which is www.medstrom.co.uk. So please swing by and have a look. Thank you. Okay, so let's have a look at another question. We've had lots of questions actually, so hopefully we will have time to cover quite a few. This is another question that's going to be directed to Shaw. Should patients be offered the chance of going to a different hospital for follow-up care? Would another hospital take on the patient? And if they did not wish to or were unable to go back to their original consultant, is this possible?
I think as a general principle, you're perfectly allowed to ask for another opinion or to change the provider of care for whatever reason. You don't actually have to tell them why. You just don't fancy it anymore. It is your perfect right, as it is your right to have an operation done in the private sector and then go back to the NHS for follow-up. There's no law against it. It's just the opprobrium that people get met with if they've taken it upon themselves to get treatment that they need wherever, whether it's privately or in another country or at a different part of the UK because the waiting list is shorter, and then they go back to a different area. So the short answer is yeah, absolutely. If you just don't have the confidence in the current provider or you've just fallen out with them interpersonally, you are allowed to ask for care somewhere else.
Thank you so much. Dr. Larmie, I have another question for you. How can we make every contact count with plus size patients, and what services are available in the community for rehabilitation?
Yeah, it's an interesting question. Unfortunately, I suppose I take issue with the services, and I'm sure Shaw will agree with me, is that we have very few resources as GPs that we can refer our patients to that are not deliberately trying to sell sort of a diet or a form of weight loss that isn't particularly helpful. So as a GP, for example, if I want to sort of refer into tier 2 services, I don't have that many options, and accessing care higher up is really challenging, and that really depends on the area that you work in. So I think that's the importance really about educating all healthcare professionals about these issues and about challenging the stigma and the bias, because if you're not able to help your patients, quite often nobody else will. It's very difficult to get our patients to see specialist teams with specialist equipment. So it is a challenge, and I think really it's about educating yourself and learning how you can become a more weight inclusive practitioner, learning how to challenge that bias rather than sticking to the old approach, which just really isn't working. So yeah, I mean, I offer courses and stuff for doctors and nurses and people who want to learn how to be more weight inclusive, and I know there are lots of courses out there, and as you say, you do your own CPD, so learn, educate yourself. I think that's the most important thing.
Thank you.
Okay, so we have another question here for Tracy. So how should we change our communication skills to suit the needs of the patient?
That's an interesting one, and I think being thoughtful in the language you use can make a huge difference in the outcome for the patient. I'm slightly averse to the word normal. I don't feel that I'm abnormal. I'm just on the scale of human experience and size. So if you could use average instead of normal, that'll make me feel a bit better. I'm going to give you my personal perspective, and I'm also speaking on behalf of a community of plus size people that I belong to. Our preferred term is plus size. Personally, I don't mind the word fat. I just find it a descriptive, but some people are very offended by it. Plus size has a positive connotation. I'd encourage you to use that as a term. I'm going to be slightly controversial now. Now, Shaw, when he was speaking, gave a perfect example of using a term with complete respect and clearly cares deeply about his patients. My community, we really don't like the expression morbid obesity. It directly translates to the words dead fat, and that's not kind, it's not respectful, it's not encouraging. I don't know of any other term which is so openly unkind to a patient group. So, as I said, Shaw uses the term with great respect, and that's fine, but it's become a term of almost abuse in the wider media. So amongst yourselves as clinicians, feel free to use it. It's appropriate, it's accurate, it's fine, but in front of your patients, please don't use those words. Please, plus size, you know, anything else, but please not morbid obesity would be my request. Thank you.
Thank you, Tracy.
Thank you.
That actually took another question, which was which term should be used. So you've managed to cover two questions in one there. That's great. Thank you. We have a question for Mr. Summers, and this is really going to your surgical background. We were asked if you could provide any tips for supporting plus-size patients post-cardiac and thoracic surgery, or particularly surgery supporting the chest when coughing and when mobilizing.
So I think the most important thing when helping patients get over surgery is talking to them about what to expect before the operation. So coaching them, saying, look, it's going to hurt, you're going to have trouble coughing, breathing. How do you normally cough? How do you make that better? And the physios are pretty good with this, especially if they've had experience in weight loss surgery services. So we pre-coach our patients about the fact that they will be got out of bed really quickly and they will be marched on the spot, and we practice it before the operation so that they know that's what they've got to do. And that it really then helps them do the right thing post-surgery. They know they've got to do it for their own benefit, and they're not learning it for the first time when they're in pain, which is not a great time to learn anything. So pre-coaching will be the best way of helping patients recover from any surgery when they're carrying extra weight, making everything a little bit more difficult.
Thank you.
Thank you, Shaw. I'm just looking here, we've got a question around, so how can we get a patient to have her very large apron removed? So I guess thinking back to your slide, Shaw, here, as currently they are refusing in the East Riding area.
It is.
There seems to be a regional challenge.
Well, there are two problems with this. Number one is finding someone to fund it, because believe it or not, it's called cosmetic surgery and there's nothing cosmetic about that apron. It's a functional skin problem. If you were to do any kind of reconstructive surgery, this counts as reconstructive. Patients with a big apron can't toilet, they can't maintain personal hygiene, they can't do anything right, and it's a treatment for a medical condition. The other problem is finding a surgeon who's willing to do it, because believe it or not, it's actually quite difficult surgery, and most plastic surgeons have no training in that kind of body contouring. So in our bariatric unit, we actually do that. We do massive apron reduction because I think it's part and parcel of good quality care for patients who need to have an apron removed. Specifically in the East Riding, I think it's worth asking the bariatric services in Leeds who would do that. Sometimes the because they've got a much better developed bariatric service in Leeds, based at St James's, and they may be able to take that on. But otherwise, I'm afraid it's a bit of a trawl around the country. If they want to come to Portsmouth, we'd be happy to take it on, but it's a long way.
Yeah. Thank you, Shaw.
Thank you. We have a question that's come in again regarding bariatric surgery, but I'd be interested, Natasha, I know you keep tabs on evidence. Is bariatric surgery the ultimate answer, or is it just a quick fix? 5-year follow-up studies show significant weight gain for the majority, but this procedure is still seen as the gold answer to obesity.
Oh, that's not at all controversial. Thanks for landing me with that question. Look, I think that you know, I don't know enough about bariatric surgery. That is Shaw's, you know, he's been doing it all his life. I'm never going to question that, and there is no question that there are benefits. I think that there is more emerging research possibly that that after the 5-year period, some people do start to slowly regain, and are not well versed enough in the evidence to be able to comment on that. What I will say is that the idea that all fat people are unhealthy is nonsense, and we have to stop talking about weight loss, I think, as this, you know, fix, this quick fix. I think the question we need to be asking ourselves is, what evidence out there is there that people are going to improve, their health is going to improve when they have surgery? And, you know, if you are unable to toilet yourself, or keep, you know, you're not able to sort of maintain simple activities of daily living, then it would make sense that of course your life is going to improve and your health is going to improve. And I think that's the important thing to remember, as each individual human being in front of you may be perfectly healthy. As Tracy says, she's in really good health, and, you know, apart from a couple of incidents that really could have happened to absolutely anyone, Tracy's in good health. So telling her that she needs to have surgery is very different to telling somebody who is simply unable to get out of bed, because that, I mean, that's two completely different people. So I think that the key here is to look at the individual in front of you and ask yourself, is this person unhealthy, or is this person just fat and I don't like that? If the answer is they are unhealthy and we need to help them, then that's very, very different to they're just fat and I'm doing sort of preventative medicine. Preventative medicine is not the same as, you know, medicine in, you know, where people actually need our help. So it's a really complicated answer. I don't know that bariatric surgery is the solution for everybody with a body mass index of 40, but I also don't think that we should discount it either. I think it is an individual thing, and as a doctor, I support every single patient that wants to go down the bariatric surgery route. I also support every single patient that doesn't want to go on a diet and wants to stay in the body that they're in. You know, it's an individual thing. That was so controversial.
Thank you, Natasha. Very diplomatic.
I think that's spot on. I would agree with every word, Natasha. I think that's absolutely right. We couldn't do surgery on everybody, even if we wanted to. But I think, if I can just briefly make 2 points.
Yeah.
We now understand that, you know, people who are heavy, it's part of a chronic relapsing problem that is down to the way you're built and down to the environment in which you live. And, you know, short of imprisoning you on a desert island with a fishing rod, there's not a lot you can do to influence that. So if someone wants treatment, either because they're unhealthy, absolutely agree, or they feel their quality of life, quality of psychological health is being hampered by their weight, then there are treatment options. And I would take issue with the questioner. The evidence worldwide is bariatric surgery is very effective in the long term if you get appropriate follow-up, and that's the problem here. The NHS is rubbish at long-term follow-up.
Can I add something as well? And amongst my community of plus size people, there are some people who have had weight loss surgery, some people are waiting for it, some people are very anti, some people are very for. Personally, I am completely on the fence, and I feel that if I became diabetic, the complications following that would definitely influence my decision to take it. I think you can't underestimate the effects of having weight loss surgery that you've had to work really hard to justify, and then finding it has failed, and that you have been either unable to lose the weight or you lose it and regain it. The psychological impact of that is absolutely devastating. And as Shaw said, the quality of support pre and post-op is an absolute lottery, and it's such a shame, because weight loss surgery in a supportive environment is absolutely life-changing in a good way, and in a bad environment is life-changing in very negative ways. So it's a very complicated question you asked us.
Yeah.
Thank you all.
Thank you very much.
Thank you.
Thank you. I think we've got time for another question. This is an interesting one to follow on from there, Shaw, because you speak about the importance of that follow-up plan. So we have a question from a community OT who has a client. She's putting together a support plan. She's reaching out to local hospitals, but is asking for any advice, would be gratefully received.
As an OT, looking for what you mean? Equipment, aids, access to care.
Yes.
I think if the patient's GP doesn't have information on pathways that the patient can enter, whether it's for treatment services or support services or just home aids, then I think the commissioners really need to be onto it. But I do know that it is a bit of a lottery around the country. For instance, the east of England, east of the A1, there are no bariatric services. There's a couple of tier 3 weight loss services, but that's in the whole of the east of England, and no bariatric surgery. Whereas you can go to other parts of the country, they're pretty well served and well served by good units. So I really do think I spend a lot of time talking to NHS England and politicians about, let's accept that there is a postcode lottery and we need to deal with it.
I work in the east of England. Hi, and I can totally testify to that. I would say approach your local primary care network. So rather than going to the CCG, which is I would go straight to the primary care network, because they're a smaller group of individuals, and that's what I would go for.
Thank you. Okay, have we got time for one more question, Debbie?
If we're very quick, maybe we can shoehorn one in. The question is, do you think that dietary advice is out of date and maybe contributing to the increase in plus-size patients? E.g., low-fat, high-carb diet is peddled by many professionals, but many plus-size patients are hyper-insulinic.
Yeah,
I'm getting lots of nods.
Yeah, it really is. We need a total rethink on dietetics and appropriate diet. And as Natasha was saying earlier, just prescribing diets does not work. How many years do we have to go around this particular merry-go-round to say that, giving patients a sheet with eat this on it does not work? And we really don't understand human nutrition. We still think we're a new thing that we've got to discover how we're supposed to eat. If you look at any wild mammal in the wild, herds of zebra in Africa, there are no big ones and little ones. The adults are all the same size because they're eating what they're evolved properly to eat. We've thrown all that in the bin when we invented agriculture. We eat what industry wants us to eat, what they can produce cheaply and quickly and make us addicted to. I should probably stop there.
Thank you. Right, we're going to have to come to a close, guys, but we thank you for your time. Thanks for the speakers. You've been amazing today. Also, thanks for everybody who's signed up for this webinar. It's been a real success. We hope you found it to be valuable. Please join us on our future webinars. We are planning another one for later this year. So many thanks from Debbie, myself, all the team at Medstrom. Please be assured that a copy of the recording will be sent to everybody who's signed up, and also we will follow up with the questions that we weren't able to answer today. So thank you very much, everybody.